Okay. Hello, everyone, or hello again. I'm Dr. Karen Skatsina. I'm the director of the ETSU Child and Family Health Institute and a professor in the Department of Pediatrics. Just want to welcome you all to our collaborative series today. In the room with me is also Katie Duvall, our coordinator for the Child and Family Health Institute. And just want to say thank you for joining us, and thank you to Dr. Beth Bailey, who is our speaker today on best practices for identifying and intervening with pregnant smokers. I'm going to go ahead and introduce Dr. Bailey. If you've not already, please feel free to introduce yourselves in the chat. You can also use the chat at any time during the session today. If a question occurs to you or a comment, we will be monitoring the chat during the session. And I know Dr. Bailey has also reserved some time to take questions and have some discussion at the end of her comments today. But please feel free to use the chat at any time. We like to make these as interactive as possible. So we also, I want to go ahead and mention this. We have a slide that we'll put up at the end, but we also have a new podcast series here that is organized out of Pediatrics, the Child and Family Health Institute, as well as with the Center of Excellence for Early Childhood Learning and Development. It's called Growing Stronger Together. And it's a podcast for people who care about children and families. So we are going to be having some conversations with many of our speakers, as well as other community members on topics relevant to child and family health in that new platform of podcasting. So you can find Growing Stronger Together and follow it like on Spotify or Apple Podcasts or wherever you get your podcasts. You can also find more information on the Child and Family Health Institute website. So Dr. Beth Bailey is a professor of foundational sciences at Central Michigan University College of Medicine, where she serves currently as Director of Health Services Research. Formerly, she was a professor and the Vice Chair for Research in the ETSU Department of Family Medicine. Dr. Bailey is a developmental psychologist and biostatistician by training, specializing in pregnancy health behaviors and the effects of pregnancy substance use on child development. She earned her undergraduate degree in psychology from the University of Michigan and master's and doctorate degrees from Wayne State University in Detroit. Dr. Bailey has directed over a dozen large-scale research and/or intervention projects funded by NIH, SAMHSA, the Department of Education, the State of Tennessee, Appalachian Region Commission, and March of Dimes. She's developed and directed pregnancy smoking cessation programs for the State of Tennessee and March of Dimes, and is a nationally recognized expert in addressing drug use during pregnancy. The long-term developmental effects of prenatal exposure to alcohol, tobacco, and other drugs, and maternal-child rural health disparities. Dr. Bailey has published nearly 200 peer-reviewed scientific papers and is frequently invited to speak at regional and national events. And she's also just a fantastic speaker and educator. So we are all in for a real treat today. Dr. Bailey, we'll turn things over to you.
Thank you so much, Dr. Skatsina. That's a lot of pressure, so I will try to do well today. But thank you so much to CFHI for having me here today. I'm excited to come back and talk to folks at ETSU. And thanks so much to everybody for being here today. I am going to share my slides. Those up here. All right, do you see those okay? I'm seeing nodding. Okay, good. All right. So I was excited as people were signing into the chat to see that we've got quite a few community health workers that have joined us, as well as lots of students, especially psychology students. So I'm hoping that this will be useful to you today. All right, let me find the navigation here. There we go. All right. So as you know, I'm going to present today on issues related to pregnancy smoking, and much of the material that I'm going to cover today, which will cover these three primary topics, I've pulled from what is actually a 3-hour interactive training session that I've developed and done many, many times over the years, and of course update periodically. But today, in the hour, well, probably 45 minutes here that we have, I want to hit on some of the main points and share some of the updated research with you. All right, so what do we know about smoking during pregnancy? I find it's always useful to start these discussions by covering the literature and the research that has been done. All right, so first of all, nationally, about 12% of women smoke during pregnancy. So this kind of helps us understand the scope of the problem. As you can see in Tennessee, the rate is 17, almost 18%. But if you look at the final bar here, and it looks like maybe the navigation here is not telling you who these are. It's like maybe the legend here has disappeared. But the first bar is the US, the green one, the yellow is Tennessee, and then the red bar is Appalachian Tennessee. And we find that in some rural regions of Tennessee, that the smoking rate in pregnancy actually exceeds 30%. So if you work with pregnant women in this region, you know that there is going to be a high likelihood of smoking among the women you're working with. All right, so when we take a look here at who smokes during pregnancy, I always caution people trying to identify who among a group of pregnant women might be smokers, to recognizing that smoking or use of really any substances occurs across socioeconomic and racial lines. There's really no usable profile of a smoker or drug or alcohol user. However, there are some trends, statistically speaking, and we've seen that white women are significantly more likely to smoke during pregnancy, while African American women are more likely to drink alcohol. Hispanic women are less likely to do both. But again, these are averages. We know that statistically speaking, women with more risk factors, including poverty, lack of social support, substantial life stress, intimate partner violence, are all more likely to use substances, including tobacco. We also know that pregnant women who smoke or drink alcohol are much more likely than other women to use illicit drugs or to misuse prescription drugs. And this means really that the health effects for the fetus are going to be compounded. It also means that intervention efforts become much more complicated. Something else I also caution about is that in some of the work I did, I found that pregnant smokers at higher SES levels and in better health were significantly more likely to deny that they were smokers. So we do have to be careful about really drilling down and finding out who truly is smoking when we're talking to women. So the bottom line is really that any pregnant women you provide care for could be using substances, not just those that seem obvious to you. In addition, if you've identified a woman to use one substance, for example, cigarettes, she's substantially more likely to be using other substances. All right. So what are the effects of pregnancy tobacco use? Okay. When pregnancy substance use is discussed, tobacco does not always come immediately to mind. However, tobacco is the most commonly used substance during pregnancy. In fact, only tobacco and alcohol use have been identified as definitively having a causal effect on adverse child outcomes. The suspected effects of other substances, while they are consistently found, could be due to co-occurring issues. Okay, so we really have very good evidence about tobacco in particular. Also, tobacco, because it's much more commonly used during pregnancy than other substances, certainly has the biggest overall impact on public health indicators. All right, so why are we concerned about smoking during pregnancy? So here's some very brief information on the suspected mechanisms of action. We know that smoking during pregnancy affects the placental functioning, it decreases nutrient and oxygen transfer, and it leads to decreased protein metabolism. Much of this comes from the carbon monoxide that's binding with fetal hemoglobin. We also know that nicotine, chemical that is in tobacco, causes vasoconstriction of placental blood vessels. All right, so the effects here result in abnormal gas exchange across the placenta, decreased fetal oxygen level, and recent research is telling us a lot more about how the fetal neuroendocrine development is negatively impacted by in utero tobacco exposure. All right. The important point of this slide here is that tobacco exposure during pregnancy has implications not only in the short term during pregnancy, but can certainly adversely affect the impact the exposed child throughout his life in many health and developmental domains. And these are listed here in that black box. So we know that growth is impacted, physical health, emotional well-being, and many aspects of cognitive development. And I'll show you a couple of these here on the next few slides. All right, so some of the known effects, we've seen substantial impacts on fetal growth following in utero tobacco exposure. By birth, the average size deficit is actually over 300 grams. And I've showed actually in a paper currently under review on a recent study my team did, it showed the impacts on fetal growth. We were looking at specific fetal growth parameters and found effects as early as 18 weeks gestation. Rates of miscarriage and preterm delivery are substantially higher for women who use tobacco during pregnancy. The growth effects that are noted at birth for children tend to persist. There has been evidence for over 20 years that these growth effects persist into early childhood, middle childhood, into adolescence. There is some degree of catch-up effect, but we still do see effects in adulthood, and that those who were exposed in utero to tobacco are on average somewhat shorter than people who were not. We see rates of respiratory illnesses and related illnesses among children prenatally exposed to smoking are in many cases double the rates that we see in unexposed children. And this is true even when we control for the fact that children exposed prenatally are likely to be living in environments where they have continued smoke exposure as children. All right, this graphic here, just wanted to really get you thinking about some other impacts. We also talk about cost and public health impacts when we look at prenatal exposure to substances. And here's a very obvious one. So the strain on healthcare resources related to preterm births is enormous, as can be the individual costs, especially among those with no insurance or substantial copays. And this really doesn't include the longer term costs associated with the consequences of prematurity, including ongoing health and developmental problems. So these are just the costs associated with the birth itself. All right, since we will be talking about interventions here as part of this talk, I do want to mention something about low birth weight and preterm birth as it relates to successful interventions. In some of the programs, we have tried to get away from telling women that if they don't quit smoking or using substances, their babies will be born earlier and smaller. So you may wonder why this is. Sometimes this is actually seen as desirable, especially among younger women. So instead, we frame a smaller baby as being problematic in the sense of smaller baby equals smaller brain, to kind of get away from that idea that, oh, a smaller baby will lead to an easier delivery. All right, so here's some examples of the longer term effects of prenatal tobacco exposure that have been found. For example, several studies have noted a 10-point or more decrease in overall IQ and language delays of more than a year by middle childhood. We see increased rates of attention problems, including a 50% increased rate of ADHD diagnosis. Elevated levels of depression, sadness, as well as increased likelihood of anxiety disorders. And we see very high rates of opposition or of OCD in children who have tobacco exposure prenatally. Substantially increased rates of conduct problems and encounters with juvenile authorities. And we also see a greatly increased risk for later smoking and substance use, and an increased likelihood of addiction when substances are tried by children who had prenatal tobacco exposure. All right. So a few final notes about smoke exposure before we move into some thoughts about intervention. So first, we see that adverse effects, not just for a woman who is smoking herself, but also with second and third hand smoke. So women who are exposed to secondhand smoke during pregnancy are putting their fetus at risk in much the same way as if they smoke themselves. Most of the effects just described for prenatal smoke exposure also occur when a woman has secondhand smoke exposure, especially when she lives with heavy smokers and they smoke around her. We are just beginning to also understand the dangers of what is called third-hand smoke. So some examples of third-hand smoke, this would be tobacco smoke contamination that lingers in carpet, in furniture, in clothes, in hair, pretty much anywhere in an environment after a cigarette is smoked. So toxins can really layer every part of that environment long after the cigarette is put out. So interventions with pregnant smokers need to recognize these dangers as well, and really talk to women about the dangers of that other smoke in their environment. All right. Another issue to note is that amount and timing of cigarette exposure are important. So how much a woman smokes during pregnancy and the point in pregnancy at which she smokes. Okay, there really is not a threshold. We do see effects with as few as 2 cigarettes per day, but certainly the greatest effects are seen at a half a pack a day or more. Also, we know that the effects on growth and health in particular occur mostly with exposure in the second half of pregnancy. There have been different studies looking at different cut points, but certainly by the end of the second trimester, we will start to see effects. So quitting smoking or even cutting down on smoking by the second trimester may lead to significant health benefits. I had a paper come out with a graduate student earlier this year that detailed the timing and amount effects. And if you quit smoking completely by the end of the first trimester, no matter how much you smoke, it's really like never having smoked at all in terms of the fetal impact. But we found that every other combination of amount and timing has led to some significant level of adverse birth outcomes, with continuing to smoke a pack per day or more to the end of pregnancy, obviously the most risky. All right, so these are important findings in terms of intervention. First, it really shows you it's never too late in pregnancy to quit and see some benefits. And while quitting should be recommended and encouraged, even cutting down can reduce the risks in pregnancy and beyond. So when you think about it, in reality, quitting smoking is hard for anyone who's ever smoked, for anyone who has ever cared for a smoker. Nicotine is incredibly addictive. Many studies suggest that it is as addictive as heroin. So it's very hard to quit. Most people have many quit attempts before they're able to quit for good. So it's helpful to know that reduction is still beneficial in reducing, but obviously not eliminating all of the risks to the fetus. And it certainly should be encouraged among women who are resistant. And it can also help increase buy-in and improve the chances of quitting completely if you can work with a pregnant woman to cut down initially. All right. So providers will often tell us that they find it difficult to address smoking with their pregnant patients because so many of them drink alcohol or use other substances, especially marijuana. And they feel that these issues are much more important to address. However, this approach is a bit misguided and it's not evidence-based, as the effect of tobacco exposure compared to other in utero drug exposures is a double or more. And I'll show you on the next slide here. But the bottom line here is that pregnant women should be encouraged to eliminate all substance use, including tobacco. So this is a table from a paper that we published a few years back from data in Northeast Tennessee, and it shows the relative impact of pregnancy smoking compared to other substance use on one indicator of newborn health, birth weight. All right, so this was biochemically confirmed substance use during pregnancy, so we weren't just relying on self-report. And as you can see, that quitting smoking would have a greater positive impact on newborn outcomes, birth weight, than even quitting other hard drug use. So illicit drug use here is actually defined. It included heroin, cocaine, methamphetamines, prescription narcotics, and women definitely need to quit those too during pregnancy. I'm certainly not suggesting otherwise, but smoking always should be part of that discussion. All right, so I do want to talk for just a minute about marijuana use in pregnancy as it continues to become more common. We do continue to find that among tobacco users, also using marijuana does not appear to additionally increase the risk of poor birth outcomes, like what I just put up there for you. In fact, I had a student give an oral presentation at the Society for Birth Defects Research and Prevention back in June, and she showed that with fetal growth markers. That was based on some data from a study in Michigan. Research more than a decade old has shown that use of marijuana during pregnancy, even when it isn't coupled with tobacco use, does not significantly increase the risk of low birth weight or preterm birth, and did not appear to increase the risk of miscarriage, other complications, or even the long-term effects. However, more recent studies have found effects. So using data from Northeast Tennessee and Colorado, I had a paper that came out a couple years ago that found significant size deficits of over 200 grams in birth weight associated with prenatal marijuana exposure and substantially higher rates of NICU admissions. The effects in early childhood are starting to be reported in the last few years and include increased risk of some specific learning problems related to in utero marijuana exposure and attentional deficits. So when you look at kind of the older research versus the newer research, we suspect that these newer findings are associated at least partially with the legalization of marijuana in much of the United States. We now have commercial grade marijuana readily available and likely used more often because it's easier to get. So we have a higher level of exposure to the harmful components of marijuana during pregnancy when someone uses it, and that is likely what's occurring. So stay tuned. The research is really ramping up to look at some of the effects from the newer marijuana use patterns. All right. So a lot of work has been done in Northeast Tennessee and other parts of Appalachia related to opioid use in pregnancy, and most everyone attending here today is likely familiar with neonatal opioid withdrawal syndrome and the other outcomes associated with prenatal opioid exposure. I mention opioid exposure here because a high percentage of pregnancy opioid users are also tobacco smokers. And in fact, our data in Northeast Tennessee found that about 80% of those using opioids in pregnancy were also smoking cigarettes. So that has significant implications because tobacco use substantially increases the risk of NOWS for newborns with opioid exposure, and it actually worsens the course of their withdrawal. So efforts to address opioid use in pregnancy, including MAT interventions, really should focus on smoking cessation for the best outcomes for mom and baby. All right, so some have asked if quitting smoking or quitting any other drug use during pregnancy would cause too much stress for the baby. All right. In fact, some of the women that we worked with in Northeast Tennessee actually told us that a medical professional told them they should not quit smoking when they are pregnant. All right. So while we know that quitting smoking is stressful and there's some evidence that chemical changes resulting from stress can affect the fetus, the harm of continuing to smoke far outweighs any small risk associated with the potential stress from quitting. According to both the American College of Obstetrics and Gynecology and the American Academy of Pediatrics, a woman should never be told not to quit smoking during pregnancy. Quitting casual use of other drugs, including alcohol, should also be recommended, and women can usually do this on their own. However, for some substances, especially opiates, and for heavy abuse of alcohol or heavy use of any illicit or prescription drug, quitting should be recommended, but probably should also be medically supervised. All right, so electronic cigarettes. What about electronic cigarettes? We are seeing use during pregnancy, and that is certainly a potential concern. I mention it because it often comes up when talking with pregnant smokers, as many see it as a safer alternative during pregnancy and may also use e-cigarettes as a tool to quit smoking. So a couple of things about the evidence there. First of all, electronic cigarettes have not been found to be effective as a cessation tool in pregnancy, and this has been shown in multiple studies. We also know that many electronic cigarettes contain nicotine, and thus fetal exposure to nicotine is still occurring. So it's the nicotine, as I mentioned, that's linked to a lot of the harmful effects of smoking in pregnancy. And we have little information yet about the possible dangers of electronic cigarettes in pregnancy in terms of both the nicotine as well as the other things being inhaled. I am actually the site PI of an NIH-funded study to look at the harms of electronic cigarette use during pregnancy. ETSU is actually one of the sites in this study. And the preliminary data suggests that chemical alterations in newborns exposed to electronic cigarettes in utero are occurring. And we are starting to see some early evidence of decreased birth weight, increased rates of NICU admissions. Final results are still pending, so I hope to have an update on that soon. We use some data here in Michigan to national or statewide data. And I had a student who submitted an abstract for presentation consideration to the Maternal Fetal Medicine Society for the upcoming meeting. And what we actually found was a significant reduction in birth weight related to electronic cigarette use compared to those not using electronic cigarettes and not using any other substances. But we didn't find any other adverse birth effects. So it was a smaller study, regional study, and hopefully we'll have more information coming soon, but there's not a lot that has been published yet on the adverse effects of e-cigs in pregnancy. All right, so screening and intervening with pregnant smokers can easily be done in the context of prenatal care. I've trained to this point probably thousands of OBGYNs, family physicians, nurse midwives, and their clinical staff who've successfully incorporated screening and intervention into their practices. However, there's many additional contexts where training can be very useful. I had funding from the state of Tennessee and the Appalachian Regional Commission 10 years ago now. And I worked with a colleague from West Virginia University, and we went out into communities in Eastern Tennessee, Southwest Virginia, and in West Virginia. And we trained a lot of other groups of individuals to help pregnant women who smoke. And these included health department staff, WIC staff, pediatric practice staff. We trained a lot of technicians, ultrasound technicians, pharmacy technicians. We trained Head Start teachers, parish nurses, other church leaders, dental hygienists, retail workers even came to some of our trainings, especially businesses that sell products for pregnant women and newborns. So this is very applicable. Anybody can do this. On follow-up, most of those who were trained found that the training was very useful in improving just their comfort level in talking with pregnant women about their smoking, and many reported success stories. We did this training with nursing students at ETSU. Dr. McCook facilitated that training for several semesters in the undergraduate nursing program at ETSU, and we had similar findings. In fact, the successes there we reported as part of a presentation at a national nursing conference. All right, so does intervention work? That's always the question people want to know. If they're going to go through this training, if they're going to go through all this effort, can the intervention be successful? All right. Fortunately, the research has shown that intervention does work. Smoking is the most modifiable risk factor for poor birth outcomes, and a woman is more likely to quit smoking and quit using other substances during pregnancy than at any other time in her life. So this is really a critical, teachable moment. Even very brief advice and practical tips from someone they trust in the healthcare setting on a one-time basis has produced quit rates for all types of drug use of around 10%. Use of the smoking quit line has also produced quit rates of 10% or more. National quit lines, as well as state-funded efforts to provide assistance, are really excellent, and they can be tailored to pregnant women who call in. Quit rates for regular brief interventions like the 5 A's I'm going to talk about right here from a trusted professional can lead to quit rates of up to 20% for smoking and 40% or more for alcohol and illicit drugs. More intensive efforts have produced smoking quit rates of over 30%. This was based on an intervention we did in Northeast Tennessee over a decade ago that put smoking cessation counselors in OB practices. So these numbers don't seem incredibly high. But when you remember how addictive smoking is, how many times people have to quit before they're actually successful, these are actually pretty good numbers, and we are still improving pregnancies for someone. All right. We also know that women who quit by the end of the second trimester have improved birth outcomes, including a 25% reduction in risk for preterm delivery. Even cutting down to less than half a pack per day has led to about a 20% decrease in risk for preterm delivery and a 44% decrease in risk for NICU admission. So those are pretty substantial. But we do know that efforts need to be regular and consistent to have a significant impact. It means you need to ask all pregnant women that you deal with about their smoking and drug use at every contact. You need to make sure that those who are smoking are followed up with regularly and consistently. All right, so the 5 A's approach to smoking cessation, this is really where the evidence has landed in terms of the best approach for intervening with pregnant smokers in a brief intervention model. And these were really developed to be implemented by non-behavioral health specialists. So physicians, mid-level providers, nurses, dietitians, social service workers, really anybody in a healthcare setting working with pregnant women. Extensive training, as I said, is not needed. Most health professionals, community members are able to effectively implement the 5 A's after about a half-day training session. Efforts need to begin early, continue through pregnancy, because it's really a structured approach to identifying and working with pregnant smokers. All right, so the 5 A's, as I said, it's a brief 5-step intervention program. It's best practice, best evidence to help pregnant women quit smoking. So here are the 5 steps. First step is to ask the patient about tobacco use. Second step is to advise her to quit. Third is assess her willingness to make a quit attempt. 4 is to assist her in that quit attempt. And 5 is to arrange for follow-up. So I'm going to spend the rest of our time here kind of walking through these steps and giving you an idea of what this looks like. All right. So the first step, asking about tobacco use. How women are asked about smoking is important. The simple "do you smoke?" forcing a yes or no answer is the most common way that women are asked about their smoking in healthcare settings, but the evidence shows that rates of underreporting are 50% or more. Rates are even higher with judgment-laden questions such as, "You don't smoke, do you?" And I have heard women asked that question in that way. So here's an alternative to the yes, no, how much questions that are often used. Depending on where you provide services, it will determine really how you document smoking and whether or not you can incorporate this into the questioning and into your documentation. But many of the practices that I've worked at have put these questions right on the ACOG forms in the medical chart or on intake forms at health departments or other agencies that serve pregnant women. And as you can see here, this allows for tracking the amount of smoking and also secondhand smoke exposure with the same type of question. All right, so asking a patient about her smoking status at her initial contact, first 5A step. Whether you interview the patient or you ask her to complete a written history form, this can be done written, it can be done orally, but these structured multiple choice questions correlate better with biologic markers of smoking, kind of our gold standard to know if somebody's smoking, than simply asking the patient if she smokes and if so, how much. All right, so this multiple choice format's been tested. It improves disclosure rates by about 60%. And as you can see here, it allows women multiple choices that might be more socially desirable than just admitting to smoking. All right, so they can say, yes, I do still smoke, but I cut down, and feeling like that is a positive thing. All right, so a patient who spontaneously quit after she found out she is pregnant, or even someone who quit about a year within the year before becoming pregnant, is at high risk for relapse. So we definitely recommend follow-up for those groups of women, even if they say they're not smoking now. But certainly you're going to move on to the next steps if you have women in the last two boxes here that indicate that they're still smoking. All right. Same question can also be used to look at secondhand smoke. Again, the same type of thing. And you could apply it with alcohol, illicit drugs, with the abuse of prescription narcotics. There's many ways this question can be used. All right. So even the best questioning is going to lead to some level of smoking denial. You certainly need to trust your instincts to probe further and ask again later. But obviously, you've got to respect what a patient or client tells you. In terms of biochemical testing, blood and urine tests of nicotine metabolites are used, but they tend to only pick up heavy and very recent smoking. Exhaled carbon monoxide detectors, like the one pictured here, tend to work much better. They detect smoking at lower levels and can go back a little bit in time, 24, 36 hours. They're often used with non-pregnant people, but thresholds, in fact, data from Tennessee, we use to develop some threshold cut points for pregnant women. They have increased metabolism, so we actually have to set the cut threshold lower for detecting smoking. An ACO can be a really useful tool, especially in research or a cessation incentive context. I've seen many women in our interventions come in for a visit and they actually ask to use the monitor. It's like, let me blow in the monitor for you. I want to show you that I quit. So they can be a very effective tool in interventions. But keep in mind that if you jump right to biochemical testing in a clinical setting, especially if you're not doing it universally with everyone, can certainly impact patient or client trust and rapport. So you do have to kind of weigh that in your particular setting. All right, so once you've asked about tobacco use and determined that someone is using, next comes advising. So the advise step should be a clear, strong, and personalized message to quit smoking that's unequivocal and includes positive messages about the benefits for both the patient and her baby. Okay, we have a quote here that is often recommended by ACOG. Most physicians report that they discuss smoking with their patients, but more than half of patients who smoke report that their physicians have not advised them to quit, which is kind of interesting. And we certainly found this to be the case in Northeast Tennessee as well. So be clear in the fact that you're strongly recommending quitting. Okay, so although this reporting from patients could certainly reflect some degree of selective recall, if you have a clear and a strong message, that'll avoid any confusion or misperception. Brief admonishments such as you need to give up cigarettes, often not perceived as strong advice to quit. So being very clear is important. All right, so after advising the pregnant women to quit, ask her if she's willing to attempt to quit within the next 30 days. So this is what we call the assess step. So we find out how much she's willing to quit. And putting a time limit on it is very important because most smokers will tell you, yes, I intend to quit someday. Okay? If you pin somebody down to a 30-day time window, sometimes the answers will change. And when you ask this question, you obviously need to be prepared for a positive or a negative response. So asking what it would take to move a distance up the scale of willingness to quit, that's one way you can help the patient start thinking about behavior change and can lead into a discussion of how you can assist. All right, again, you can do the same thing with secondhand. All right, so why do we assess readiness to change as part of the 5 A's? So in order to be effective in assisting behavior change of any kind, we really need to meet patients or clients where they are. So changing behavior is a process. We need to figure out where the patient is in that process in order to best support them. And the goal really in any health behavior intervention is to move a patient toward a more advanced stage of readiness or action or a willingness to change. Right. So depending on where a patient is, and here's the stages, and I don't have time certainly to go into readiness to change as a model, but when a patient is not yet contemplating quitting as opposed to being ready to jump into action, you're going to work with that patient very differently. So it's very useful information to have as you try to assist a patient. All right, so if a patient wants to try to quit, you obviously want to reinforce that, let her know how pleased you are that she's willing to try to quit smoking for herself and her baby, and then you move on to the assist step. If she says that she's unwilling to try it this time, you let her know that you understand it's a big decision. Support's very important here, but certainly reinforce the potential health benefits for her and her baby. It can also be helpful to try to find the reasons why she does not want to quit at this time and then discuss how those might be handled. I have been surprised many times by the reasons that women have given me for not wanting to quit smoking. Everything from not being able to hang out with friends for a smoke break, to her husband who also smokes. She's afraid he'll give her a hard time because he thinks her quitting and him not will lead her to feel that she's better than him. Okay, so there's lots of reasons that women will give, and obviously how you're going to work with her is going to be very dependent on those things that might be interfering with her willingness to quit. All right. So it's important to understand smoking is an addiction. The drug is legal and readily available, so it's hard. Pointing fingers, blaming the patient, being judgmental is certainly not an effective way to offer assistance with smoking cessation. Okay, recognize that there is going to be an actual physical addiction that you're going to have to talk about in addition to all the behaviors that surround that smoking activity. All right, it's also important not to feed into the patient's excuses for smoking. Okay, so you can certainly acknowledge those are the reasons why she smokes, but then focus on those how those can be managed or dealt with without smoking. In addition to not being judgmental, certainly recognize your own biases, finding ways to encourage pregnant women to quit. I have trained many people to work with pregnant smokers who themselves smoke. And had to really think about what that means in terms of working with those patients. And I really told them to talk about framing that as a way they can relate to that patient and that they recognize how hard it is, but that they hope that that person can be more successful than they have been with theirs. All right, so assisting with cessation also needs to recognize the unique challenges of being pregnant. So with that, the stress due to pregnancy, many women actually increase the amount they smoke after they find out that they're pregnant. So you really need to meet women where they are in terms of their feelings about pregnancy and in terms of their feelings of how it means for them to continue smoking and what that means for the pregnancy. Now, someone harping on them about needing to quit smoking may only make the emotional experience worse and increase their smoking even more, which is definitely not what you want. So you need to be very mindful of where a woman is related to how she feels about her smoking and build on her strengths, not go after the weaknesses. All right, so effective discussions while assisting pregnant smokers are much like any other discussions about health behaviors. Open-ended questions can be the most useful. Finding out the role that smoking plays in her life is important. People who smoke do so for a reason. So at this point, it may just be to avoid withdrawal, but there are lots of positives from smoking, including stress relief, to be social, and those really need to be understood before quit attempts will be successful. Talking about what worked and what didn't in past quit attempts can also be useful. Most people who smoke have had at least one quit attempt. Most research has shown that cessation is much more likely if interventions evoke internal reasons to change versus external. So encouraging her to change for herself or for the health of her developing fetus or for her own confidence rather than to please other people, it will be much more successful. It's also helpful sometimes to ask her what she knows about the potential dangers of smoking. It can help start the conversations with the information coming from her. You can also ask women what would be the benefits of quitting and get them start thinking about a life without smoking and how life might be better. Certainly materials on the immediate and long-term health benefits for mom and baby can be provided, giving her some handouts. These efforts tend to be more effective if they're framed in the positive. In other words, how health will be improved if they quit rather than in the negative, the harms if they continue smoking. Stress how immediately these effects can be seen after quitting. Oxygen to the fetus can actually increase within hours of quitting. Also, it's important to point out sometimes the cost savings. A lot of times they haven't really thought about how much cigarettes are costing them. A pack per day smoker spends almost $3,000 a year on cigarettes. So talking to them about how they might be able to use that money if they quit smoking. All right, so some additional suggestions are here. One thing I found helpful is repeating back patients' words is less likely to create resistance in counseling, kind of a standard counseling or therapeutic technique. So you like how smoking reduces your stress. At the same time, you say you worry about your baby being born healthy and having a non-complicated pregnancy, gets them starting to talk about some of the ways they might address kind of this disparity. Final bullet point here about withdrawal symptoms. Cravings will pass within minutes, whether or not you smoke a cigarette. Sometimes that can be a really powerful message to smokers. They know that it's going to get better, even if they don't smoke, and it helps them maybe develop a plan to manage initial minutes when they smoke or when they are craving a cigarette, rather than being overwhelmed and unable to make a decision in that. All right, secondhand smoke. Here's some suggestions for dealing with secondhand smoke elimination. One thing I have found in working, especially with women, more disadvantaged women around smoking cessation, many of them don't have control over their environments, even the environment in their home. And so it's really important to recognize you can't send them home thinking they can tell everybody to quit smoking around them, because they may not be able to make that decision in their home. And so talking to them, potentially involving the family, finding smoke-free zones, or really having them engage in a discussion with the family, or bringing the family in when they come, so that you can talk to them about ways that health can be improved by them not smoking around her. One thing I always make sure I hit on is discuss smoking in the car. That's the most concentrated place you're probably ever going to be exposed to smoke. And so getting women to really try to find ways to eliminate riding in cars with other smokers. All right, so here's some additional tips as a woman commits to trying to quit. Lots of things you can do here. Contracts tend to be very useful. Helpful for women as they try to quit, kind of giving them something to hold on to. We gave these to women, maybe took them home, put them on the refrigerators. Other things suggest the removal of all tobacco products from their environment, so they're not there and readily available. Put social support firmly in place, both from you, and make sure they've got good support at home, and making sure they've got the information. All right, so here are some general topics you might find helpful in assisting each individual woman to quit. You can probably find handouts, pamphlets related to all of these things. Gaining weight, usually not as much of an issue with pregnant women, but it becomes a huge issue for women for postpartum relapse, and talking about how you can continue not to smoke and not gain. All right, some additional things, very practical, hands-on suggestions to address specific issues, things to do with their hands and their mouth, typical for anybody trying to quit smoking. Assist us for quitting without gaining weight, giving them some things, ideas, different things to do. All right, so one thing I have encountered that I just wanted to point out to you, you may see it too, is I've had patients say things like, I smoked with my first child and he or she was okay, or my mom smoked with me and I turned out okay. So in working with a patient who's had previous smoke-exposed pregnancies with no apparent smoking-related gestational and developmental complications, some things you can do. Conduct the counseling while really emphasizing that many circumstances can vary between pregnancies that may significantly impact the degree to which the fetus will be harmed by smoking. And many of these are listed here. Differences across pregnancies, different effects. Okay, it's also important to recognize that effects may be subtle. Those frequent ear infections, overactive behavior, okay, those types of things may all be related to that prenatal exposure. So really emphasizing, again, quitting smoking will ensure that their child will have the best possible start. All right, quick note about pharmacologic intervention. It is preferable for pregnant patients to quit smoking without using pharmacologic agents. They have not been sufficiently tested either for efficacy or safety in pregnant patients. So they're really not recommended as first-line smoking cessation therapy. In fact, the sole clinical trial that was done with pregnant women was actually discontinued due to adverse effects. Women who smoke heavily, more than a pack of cigarettes a day, and have been unresponsive to behavioral therapy may need to consider adding a pharmacologic age to their intervention plan. For these patients, the risks of smoking may outweigh the potential risks associated with the drug therapy. In this instance, nicotine gum is the safest. We encourage pregnant women to stay away from nasal sprays and patches in particular, just because of the ongoing exposure. And Chantix has not been shown to be safe in pregnant women. If a patient is very interested in pharmacological treatment, encourage or discuss this with the physician if you're not the physician. All right. So finally, arrange. So you've asked, you've advised, you've assessed, you've provided assistance. The final step here is arranging for follow-up. So follow-up visits should include repeated assessments of smoking status, review the goals that were set, discuss concerns or difficulties, consider involving family members as quit buddies or sponsors. For patients attempting to quit, follow-up visits should include time to monitor their progress, reinforce the steps they're taking, encourage them to succeed. Patients who are heavy smokers or who continue to relapse may need more intensive counseling, and they might need additional outside resources or referrals. But above all, it's important to be supportive and express a willingness to. All right, as mentioned, understanding what the patient likes about smoking can help you tailor an intervention that will address meeting these needs. Important to remember that there are always reasons not to change. So listing both the positives and negatives of the change can be helpful. We all know this from our own experience trying to change behaviors. All right, cutting down is important too and should definitely be reinforced. Even brief quit attempts have fetal health benefits, and each one increases the likelihood of eventually quitting for good. So make sure you celebrate all of those even small successes with my patients and clients. All right, so I have a scenario here. I think maybe in the interest of time, I will skip over it, but I will let you take a look at some ways you can solve it. We'll make these slides available to you certainly. All right, one thing I do want to mention here is the idea of post-delivery, post-quitting assistance. So the majority, unfortunately, of pregnant women who quit smoking relapse, and by 6 months after delivery, about 75% of them are smoking again. And that 75% is actually data from our work in Tennessee. But we also showed that the primary driver of successful continued cessation is family support. So it's really important to work with the woman to get her to a place where she's got family support, where she's got people who are going to support, or at least not sabotage, her continued cessation efforts. Obviously, follow up, be positive about the continued benefits to mom and baby for remaining smoke-free. All right, and then the last slide here is just some of the papers published that I mentioned, some of the research related to the presentation that I gave today, but I'm happy to provide additional information or materials on request or support of anything that was mentioned in this presentation. And I would be happy to take questions. And thank you all for sticking with me through that long presentation.
Thank you so much, Dr. Bailey, for your presentation. And we've got about 8 minutes left, so we will open it up for questions. There was one question already that I saw in the chat, so I'll kick us off by sharing that question. But feel free to put additional questions or comment in the chat, or raise your hand. You're also welcome to unmute yourself to ask questions. I thought it was a really good point, and something that I worry a lot about. We have so much focus in our region by necessity on prenatal drug use and exposure, and I feel like sometimes we don't put as much emphasis on tobacco cessation as we should be. So I appreciate you sharing that statistic. It's encouraging that basically any intervention, even a small dose of an intervention, can be helpful with pregnant women. And I'm also intrigued that family support is so important for sustaining quitting. And interested to see what ideas folks have about engaging the family. But the question in the chat was about the relative value of counseling in person and intervening in person versus doing that, say, by text messaging or some other telehealth platform, partly because we've got programs that are delivered virtually or through telehealth in the area. So any comments on that, Dr. Bailey?
Yeah, so there has actually been quite a bit of work done on text interventions related to smoking cessation. The March of Dimes actually supported quite a few of these, and the data was really promising as long as the efforts were consistent and as long as the person felt personalized as part of that. So not just the standard text messages, that everybody gets, but if those efforts were personalized, those tended to be almost effective as the in-person effort. Now, I will say we don't have a lot of information yet about virtual. That's relatively new with COVID that we've been trying to do some of those. So data is still pending, but some of the early stuff I've seen has shown that those interventions are pretty successful. All right. And I see Daniel, you have your hand up. You want to go ahead?
Yes. I was curious, there's that window in the beginning of pregnancy where women generally don't know that they're pregnant, but say that they are heavy smokers at that point in time. Are there steps that they can take, say they actually successfully quit, and are there medications or foods that they could eat to help lessen the damage or potentially start to undo whatever damage was caused initially?
Right. Well, fortunately, what we have seen is that the smoking in the first trimester does not seem to have lingering effects. It's early enough that it is not, unlike what we've seen with alcohol, fetal alcohol exposure, which first trimester is very critical. Smoking does not seem to be the case as much. And so if a woman quits by the end of the first trimester, most of the research has shown that it is if she has never smoked in terms of the effects on the fetus and ongoing child health and development.
Cool. Thank you.
Yeah, you're welcome. All right, so I see, the other question is the one that Dr. Skatsina just read. Anybody else?
Hi, Beth. I got a question for you.
Yes. Hi.
So I have always thought that studies on nicotine replacement are going to be rare because the market is too small for the companies to make money on it. And that a nicotine patch with one chemical was safer than a cigarette with, some would say, 100 chemicals. So we've not shied away from nicotine patches for those people that want them. I just wonder what your thoughts were, because you mentioned that some people aren't fans.
Yeah, so it's obviously mixed, and Dr. Olson, you as a practicing OB, I would definitely refer to your clinical judgment, but I will say that the trials that have been done have not shown safety. We've not shown significant harm, I don't think, but we certainly don't know. And as I mentioned, if you've got somebody who is a heavy smoker, just can't seem to quit otherwise, then certainly you want to find some avenue to help her quit. Do you recommend patches as opposed to things like gum typically?
We try and leave it to the patient.
Okay.
I think we probably write for more patches than gum because that's what the patients ask for. And certainly I think that there's probably a need to increase physicians' knowledge on how to use patches. They think, here's your patch and go forth, and they don't really talk to the patients about cutting down their dose of nicotine first and using them properly.
Right.
So,
yeah. And that's the fear, right? That she's going to put on a patch and then continue to smoke. And then you've just increased the nicotine exposure for the fetus. So certainly efforts to make sure she's quitting as part of that are obviously important. No, great question. And I wish we had more data, frankly.
I have a question. I noticed that you had some statistics about the co-occurring substance abuse, such as marijuana or maybe harder drugs, opiates, when they smoke. Have you noticed anything in patients who have quit substance abuse? You said that some say they smoke because they have quit other substances in the past, and so that kind of probably keeps them from relapsing. Do you have any statistics showing of any increase in relapse on substance abuse if they do quit smoking?
Yeah. So oftentimes they'll substitute one drug for the other, as you're suggesting. And so sometimes as a woman is trying to quit marijuana or opioids, for example, she might increase her smoking. And so if we cut off all substances, there is data to show that she is more likely to relapse any substance, whether it's smoking, whether or not it's the other drugs. It's obviously really important, but I have seen many substance abuse treatment centers that are focusing on opioids or other drugs that really don't pay a lot of attention to smoking, right? They continue to smoke. And part of that is just the reality of getting them to quit everything at once is probably not a practical goal. So pregnancy is hard because we've got a really tight window when we want to get them to get off everything. And we need to really think about how we're going to do that effectively. So great question.
Also follow up on that. There are, like you said, there are clinics that focus solely on opiates. I've noticed like the Subutex clinics. Is that truly safer than opioids, or?
Well, I mean, there is a definite evidence that birth outcomes are better for women who are on medication-assisted treatment, Subutex being the primary one as opposed to methadone for pregnant women, but methadone is certainly used as well. Mostly because it's consistent. We know the dose, she's in treatment, but we're going to have babies who are going to withdraw as a result of that. And there can be long-term developmental effects, but it's certainly preferable to what they were doing before. I know we've got Dr. Olson on, who this is kind of his area of expertise. Dr. Olson, do you want to add anything to that?
Sorry for my delay. It's lunch break.
No, that's okay. Sorry to put you on the spot.
15-minute lunch hour here. So it's Jesse, it's a controversial topic. So the official answer is American College of OBGYN, there are no long-term effects from buprenorphine in pregnancy. It's an easily treatable disease, and you should never taper. So that's the official. And so one of the things I do is break all those rules, because it's 10% of patients in Johnson City, Tennessee are on buprenorphine. It's probably higher than that in Sullivan County. And all you have to do is go find a first grade teacher you're seeing as a patient, ask her, because she's got 3 of these kids in her class, and she knows how bad it is. So their brains are smaller, their MRIs are different, and their school performance is worse. So part of the challenge we have is when we have the appointed experts saying there's no problem, when we're looking at it and there is, then what do we believe? So I would say that the dose of buprenorphine is the challenge, and 16 milligrams is the dose that's out there as the standard dose, and that's the same equivalent as 48 4-10s a day. And so I would hope that in your generation, we're going to figure out that the Suboxone clinics of today are the same as the pill mills of the 1990s. The right amount of opioids treats pain and suffering, and the wrong amount causes an opioid epidemic, and the right amount of Suboxone treats addiction, and too much causes an NAS epidemic. So that would be my answer. That is not the politically correct answer. That answer I gave you is wrong on every test you will ever take.
Well, I appreciate your honesty. Thank you so much.
You bet.
But it is the reality of practice, and related back to smoking, again, if we can get these women to quit smoking while they're on the MAT drugs, we definitely have better outcomes.
And Beth, this is Jack Woodside. I'd like to add one thing to what Marty was saying. I mean, MAT with either buprenorphine or methadone cuts overdose mortality by half. And certainly if the mother overdoses, that's harmful to the fetus. So
absolutely.
The question I had for you is, since so many of the adverse effects are mediated by nicotine, it makes me wonder whether other pharmacologic aids other than nicotine replacement might be advantageous. Now, I heard you say that there's no data showing safety for Chantix, varenicline during pregnancy. Is there any data showing harm for either varenicline or bupropion in pregnancy?
I haven't looked probably in the last 2 years. I know that as of about 24 months ago, there was nothing strong out there that showed substantial harm You just know in pregnancy, we err on the side of let's make sure we know it's safe before we do it. But certainly, again, that's going to have to be a clinical decision, weighing the risks and benefits. And we just don't have a lot of information, unfortunately, right now. But thank you. Yep. You have expertise here as well. I see Dr. Kraus has raised a hand.
Hi, Dr. Bailey. Thanks for
Hello.
chatting with us. I unfortunately missed the very beginning of your talk. I was coming in from something else. So if you already said this, I apologize. Your methodology for assessing the tobacco use during pregnancy, I was just curious if you have any suggestions on how to assess that, or what has worked the best for you and your collaborators if we don't have access to the patients during their full pregnancy, but maybe just at the end. What are the most methodologically sound ways to get them to reflect back on the frequency and duration of tobacco use?
Right. So, the timeline follow back method is kind of the gold standard, that we've used for alcohol for forever. It can be used with tobacco as well. Since women who smoke tend to do it every day, it's actually a little bit easier with tobacco. Certainly, you can use exhaled carbon monoxide monitors. Those are really seen as kind of the gold standard in a research setting, and can be used clinically. And if you're doing something after the fact, the cord blood is also a really good indicator of the nicotine exposure as well.
Quantitative numbers from the cord blood?
Yep. Yep. The quantitative numbers from the cord blood you can get at amount. And even exhaled carbon monoxide, we've developed some algorithms based on their value that they blow in equating that back to a number of cigarettes. Not perfect, but it's decent.
Well, we are at the end of our time together today, and certainly I can leave the Zoom open and folks do have a couple more minutes for discussion. I wanted to mention one comment in the chat from Dr. McCook, and I thought the same thing, stunning to think that smaller preterm infants are perceived as desirable. So that was interesting insight that you shared in regards to how maybe our younger moms or some of our moms may view that. I am going to share my screen just for a moment so I can put this information up about our podcast series, but just want to thank you again, Dr. Bailey, so much for being with us today, and everyone. It's been a great discussion.